Hello, my name is Phil Verhoef, and I'm going to be presenting a webinar today on pandemics and public health emergencies. I am an ICU physician in Honolulu, Hawaii, and I have been caring for patients during this COVID pandemic, including those patients who suffer from the coronavirus infection. I'm also a board member of Physicians for a National Health Program. We are the largest physician advocacy group fighting for healthcare reform based in single payer, improved Medicare for all. And I'm going to talk today a little bit about my observations and my experience caring for patients during this pandemic and the impact this pandemic has had on our healthcare system, especially our public health system. And perhaps the most important point that I want to drive home is that now more than ever, we need single payer Medicare for all. This pandemic has revealed to us how flawed, how broken, how fragmented our current American healthcare system is. And so, well, let's talk a little bit about the nature of that fragmentation. The basis for it is in the fact that Americans receive their healthcare coverage from a wide range of different suppliers. So the majority of Americans, as you see in the pie chart here, receive their healthcare insurance from their employer. And that means that their employer contracts with a private health insurance company. The employer will pay a portion of the premiums for the insurance, and the employee will also pay a portion of those premiums. It means that the employer gets to decide what health insurance options you have, and they may offer you 3, 4, 5 different private insurance plans, and that's what you get. Heaven forbid the doctor that you want to see isn't included in the options that your employer provides. But regardless, about 178 million Americans get their health insurance coverage via offerings from their employer. Now, about 17.8% of Americans get their health insurance through Medicare. Now, if you recall, Medicare is the closest thing we have to a single payer in this country. That is a health insurance program specifically designed for people over the age of 65. It's been around for about 50 years, and it was implemented because we recognized that when people when people got older, they retired. And when they retired, they no longer had health insurance. And yet, people that get older are among the most vulnerable, the people that need health insurance the most, because, of course, as we get older, we are more prone to illnesses, and we need that healthcare coverage. And so, the implementation of Medicare was a recognition of that. And so we have this Medicare system, the single payer that covers the health costs for our folks over 65 in this country. We also have Medicaid. This is another government run program, but it is specifically designed for people that live below a certain means. This is a means tested program. And in order to qualify for Medicaid, you have to make less than a certain amount of money. And that obviously depends on, whether it's just you or your family, but this is really the program that is designed to help those who are below a certain means in terms of their annual incomes. And that covers about 18% of Americans in this country, so a fairly large number. About 11% of people purchase their health insurance on the health insurance exchanges or directly from the private insurance company. And of course, we saw an explosion of this 10 years ago with the implementation of the Affordable Care Act. But nearly 11% of patients out there get their insurance through one of these private direct purchase plans. Now, about 8.5% of Americans are uninsured. That means they have no health insurance, and when they get sick, there's no insurer to help pay the bills. There's nobody to cover that expensive hospital stay. I work in the intensive care unit, and the cost of care in the ICU exceeds $5,000, $8,000, $10,000 a day. Imagine not having insurance and suddenly getting sick, requiring the ICU, and then being saddled with hospital bills that are thousands and thousands of dollars. Obviously, that's not good for anybody. And about 3.5% of Americans receive their health insurance through either the Veterans Administration, the VA, or through TRICARE. And these are people that have either a current or a prior military service connection. And so you can see the wide range of different ways people get health insurance for their care, or they don't have insurance at all. And it is this fragmentation that is underpinning all of the problems in our healthcare system today and has contributed to the struggles that we're having in the current COVID-19 pandemic. And we're going to dive into this in a little bit more detail. But the first point I want to make is actually a good one, that Medicare, our system for our folks over the age of 65, has inadvertently made it easier for all Americans to get medical care during COVID-19. And I know you're going to be asking yourself, well, how could that be? I thought that Medicare was only for people that were, over the age of 65 that qualified for it. But indeed, in mid-March, the Centers for Medicare and Medicaid Services announced that Medicare would cover telehealth. Well, what is telehealth? This is your ability to interact with your doctor, but not in person. You can use your phone's camera, you can use your computer's camera, but basically you communicate with your physician online or via phone, and that avoids the need for physical contact. And of course, we're in the midst of this pandemic where there are stay-at-home orders, there's mandatory social distancing, and that makes it really hard for people to get medical care. And I think perhaps the most important element of this is that patients can continue to see the doctor when they need to. And this means medical practices can remain viable. Because one thing that we have seen during this COVID pandemic is that private practice doctors are literally closing their doors. They're shutting down because if patients aren't allowed to leave the house, patients aren't coming to the doctor. If a doctor's office can't provide personal protective equipment for its staff, they can't safely see patients. And so we're seeing private practices absolutely struggle during this crisis. And now that Medicare is actually going to pay for telehealth visits, those practices can continue to actually function. No, they don't have to have patients coming to their offices directly. They can just communicate with patients in the privacy of the patient's own home. Patients can continue to get care. Doctors can continue to get paid to do their job. And I think everybody wins. But the thing that was so remarkable about this is that shortly after Medicare said, hey, we'll pay for telehealth visits, all of the private insurance programs said, we will too. Prior to this point, doctors couldn't get reimbursed for their time for telehealth visits. And so, nobody was ever setting up systems like that. If they aren't going to get paid to interact with patients via the internet or via phone, then doctors aren't going to set those systems up. But now Medicare is saying we'll pay for it, and all the private insurance companies are following suit. And that means all of us with employer-sponsored healthcare insurance, all 178 million of us, now actually get more access as a function of Medicare being able to be bold, to be innovative, to say this is the new way that we need to cover healthcare in this country. Now, of course, if we had Medicare for all, it would work so much better, right? We wouldn't have to wait for the private insurance companies to say, "Oh, Medicare is doing it. I guess we should too," and therefore, it's going to be good to continue to provide access. Right now, we're depending on private insurance companies to do that. But if we had Medicare for all, we wouldn't have to. Instead of Medicare saying we'll cover our seniors and private insurance following suit, Medicare would simply say, all right, everybody in America, all 350 million of you, you'll be able to still see your doctor by telehealth, and we will cover it. In addition, of course, we would be able to roll out new public health strategies that optimize social distancing in the setting of a pandemic like this. And so let's look a little bit more carefully at how other industrialized nations have been dealing with this pandemic. Well, So one thing that nearly all other industrialized nations provide is universal health care. They make sure that their citizens get all medically necessary care when they need it. They don't implement financial barriers to keep people from getting care. That is a uniquely American feature of our healthcare system. And other countries actually build the infrastructure that can respond quickly and easily to make sure that resources are provided in the setting of a surge or a pandemic. In addition, other countries create social protections for people affected by COVID-19, and ultimately different countries use different models. Some countries use a government-run health insurance program. Other countries, all the doctors and hospitals are employed by the government or owned by the government. And some countries create a partnership between private health insurance companies and the government in order to assure universal health care. But it really doesn't matter what the model is. What we know is that these countries with universal healthcare programs are uniquely able to respond to this pandemic. And let's look at why. Well, we talk about single payer being a necessary element of this, but it's not the only thing, right? Single payer is necessary for fighting a pandemic, but it's not enough. We need investment in the public health systems in this country in order to fight pandemics. Look at what China did. So, China, the outbreak started in China, um, but China was able to mobilize 9,000 epidemiologists just in Wuhan. Wuhan is a city of about 10 million people. So, it's a little bit bigger than New York City, a little bit bigger than Chicago, but not that much bigger. They mobilized 9,000 epidemiologists in Wuhan to help manage this outbreak. That's more epidemiologists than we have in the whole of the United States. That is an example of investment in a public health service to manage an epidemic. In South Korea, the government committed to covering the financial costs for testing and treatment instead of any possibility that individuals would be saddled with those expenses. And so, if people are mandated to get tested because of an exposure, they're not going to be saddled with the bill for that in South Korea. In Taiwan, they took it a step further. They said, if you're going to be isolated, we'll pay for your food, we'll pay for your lodging, we'll pay for your medical care. Because think about it. If you're worried you might have COVID-19, well, you maybe don't want to go to the doctor, because if you find out that you're positive, you're going to have to be quarantined at home. You're going to lose wages because you can't work. You're going to have a difficult time then potentially paying for your food, paying for your lodging. And so you actually have a disincentive to not find out that you have COVID-19. But in Taiwan, they said, look, if you get COVID and you're forced to be isolated, we'll take care of all of those other things. These are the kinds of social protections that a well-informed government-run system can actually run. And we're seeing it play out in Taiwan and protecting their citizens. And in Italy, where the COVID-19 pandemic is absolutely raging through the country, Italians don't have to worry that they have to pay for their care or to pay for any of their tests. And you know what? We can't say the same in this country. In the United States, people do have to pay for their care. They do have to pay for their testing. They do have financial disincentives to going to the doctor. They do lose wages when they get sick. But if we created a well-funded single payer in this country, we could do what all of these other countries are doing and so much more to try and protect the public's health. And so now we're going to spend a little bit of time talking about all the flaws in the current American system and all of the ways that a good single payer Medicare for all system would help address that in this pandemic. So one of the things that we have known for more than 40 years is that when you saddle people with costs, that keeps them from seeking testing and treatment. Under the current system, 30 million Americans don't have insurance. That means they have to pay for everything themselves. And, if you're faced with an expensive healthcare bill, you're not going to bother going to the doctor because, of course, it's too expensive, right? You can't afford that. But 70 million Americans do have insurance, but the insurance plan has such a high deductible that you still can't afford to seek care. And this kind of blows my mind, right? Why do we have insurance? But to protect us from financial catastrophe when we have a medical catastrophe. It's literally to protect us from, becoming bankrupt. And yet, if you have a health insurance plan that doesn't kick in until you've spent $5,000, you're not at all protected from financial catastrophe. You have insurance, but it's not good for anything. It's not protecting you at all. And so we know that if you have no insurance or if you have high deductible insurance, you're going to delay seeking medical care because of cost. But what does that mean? That means that we create opportunities for this pandemic to actually get worse because people aren't coming to medical attention. They're not getting tested when they have COVID. They're therefore not knowing that they need to be quarantining. They are continuing to spread this infection, at their workplace or anywhere they come into contact with other people. And that's only going to hurt us as a society. Now, under a single payer Medicare for all system, we would have no out-of-pocket expenses. Again, we know healthcare costs deter people from coming to the doctor. So let's take away those out-of-pocket expenses so that people can simply say, gosh, I think I'm sick. I need to go to the doctor. I need to go to the hospital. Boy, I'm glad I don't have to worry about paying the rent when I get that doctor's bill or when I get that hospital bill. Let's take that worry away, and we can do that with a Medicare for all system. Perhaps more importantly, when a vaccine for this coronavirus finally does become available, or when a drug is finally developed that can cure people of the coronavirus, we can actually get it to people without concern that they won't be able to pay for it. We may have a vaccine for coronavirus, but if you can't afford it, you're not going to get it. And so you're going to roll the dice on getting the infection and potentially dying. Right now, we see that around 2% of people are dying of this virus. Those are not odds that I want to take. And so if we have a single payer Medicare for all system that covers treatments, that covers vaccines, we know that we can distribute that to everyone and we can stop or at least slow the spread of this deadly virus. Related to that, people can't afford prescription drugs. Right now, again, 30 million Americans don't have insurance, so they don't have prescription drug coverage. And that means that if they need a life-saving drug, they have to pay for it out of pocket. You've probably heard about how expensive insulin has become. The cost of insulin has actually skyrocketed. Well, heaven forbid you develop diabetes and don't have health insurance. You're going to be spending all of your money on the insulin that keeps you alive. But more than that, many people that have health insurance have drug coverage that is inadequate. They have high copays associated with their drugs. And so what do? Well, they don't fill their prescriptions at all. Or they take the prescription and, cut it in half, make it stretch a little bit longer. These are the kinds of decisions that people make when they can't afford their drugs. And this, of course, leads to a more unhealthy population. In addition, drug companies, pharmaceutical manufacturers are controlling our drug supply. They have a stranglehold on the drug supply, and they don't have any incentive to develop any new therapies if those therapies aren't going to be profitable. And so, we need new therapies for this coronavirus, but if there's not the incentive of profit, what's the incentive for a drug company to make that investment? We're also seeing a huge problem in this COVID pandemic. We're actually running out of drugs that are common. In the ICU, we use medications like fentanyl and midazolam to help keep our critically ill patients comfortable. And we've got a national shortage of those because there's so many critically ill patients in this country. But we can't get more because we don't have any way of expanding that supply. We're completely at the will of the pharmaceutical company, and if they don't want to make more, if they want to capitalize on the scarcity of this drug to drive prices up, as often happens in an economic system like this, we can't do anything about it. And so we continue to deal with drug shortages in this country, and we don't have a solution. Under a Medicare for All system, of course, as we've said before, there'd be no out-of-pocket costs, right? So people will get the drugs they need without having to worry about spending money that they would otherwise need for rent or a mortgage payment or to put food on the table. We take that calculation off the table. Nobody should have to make that decision. Gosh, should I pay for my drugs or should I pay for my dinner? In addition, if we had a Medicare for All system, that system could negotiate drug prices with the drug companies on behalf of all Americans. This is a model actually that the Veterans Administration uses, and the VA spends much less on its drug formulary than Medicare does, because the VA can negotiate with drug companies to say, look, we will purchase this drug from you at this cost. The VA leverages its buying power as a system that covers millions of Americans. Medicare would be able to do this as well, but currently Medicare is forbidden to negotiate with the drug companies. A Medicare for All system would change that. In addition, we could create an actual public drug manufacturing system so that during an emergency, we don't run out of fentanyl. We don't run out of midazolam. We don't run out of hydroxychloroquine because, of course, people have been snapping it up on the hope that it would treat COVID. People actually need that drug to treat their own illnesses, and they can't get it. Under a Medicare for All system, we can create public drug manufacturing capacity so that we can respond to these kinds of problems in the setting of a pandemic. And lastly, we can increase public funding of research and development for novel therapeutics instead of depending on the profit motive that a drug company has. We increase the public funding so that we can develop novel therapies within the public sector and roll those out to patients without needing to depend on a for-profit system to do that for us. We're also facing a tremendous difficulty with under-resourced hospitals in this country. What do I mean by an under-resourced hospital? Well, I mean rural hospitals. I mean hospitals that take care of patients in inner cities, hospitals that have high costs but low revenues by virtue of either where they are or the populations that they care for. And right now, we know that the coronavirus infection is disproportionately impacting vulnerable populations. It's disproportionately impacting people in inner cities. It's disproportionately impacting people that are poor. It's disproportionately impacting vulnerable populations. And so more of them are going to the hospital. They're more likely to be uninsured. These hospitals need to absorb the cost of treating them because they don't have insurance. They're not going to be able to pay their hospital bills. These bills, especially if they end up in the ICU, will be tens, hundreds of thousands of dollars. The hospital's got to eat that because they're not going to get paid for it. In addition, hospitals are already burdened by a tremendous amount of administrative waste. Hospitals spend as much as 25% of their revenues on insurance and billing work. What does that mean? That means that every dollar that goes into a hospital, 1/4 of that is simply spent employing the people to be administrative bureaucrats. It's employing people to interface with insurance companies. It's employing people to get those pre-authorizations taken care of. It's employing people to review charts and decide how much this visit should be billed based on what the physician documented. It's employing people to interface with the insurance companies to fight denials, right? When the insurance company says, no, we're not going to pay for that, somebody at the hospital says, yes, we need you to pay for it, and there's a negotiation that happens. 25% of a hospital's revenue goes to pay for people to administer this crazy fragmented insurance system that we have. That's money that's not being spent on providing healthcare for patients. And particularly during a pandemic like this, we can't afford to have to fight with insurance companies about what's going to be covered and what shouldn't be covered. It would be so much better to redirect that administrative waste into simply providing healthcare. Under a Medicare for all system, rather than reimbursing hospitals on a sort of fee-for-service per patient basis, we fund the hospital through what's called an annual global operating budget. This is the same way that we fund police departments, fire departments, other public goods in this country. You look and say, you look and see what that hospital has spent on providing healthcare, for the community that it's in, and you say, all right, this is the amount of money that you get for that. And if you start to see more patients, or if there's an emergency, if there's a pandemic, we will simply increase the amount of money that we direct to that hospital to continue to provide care. It won't depend on how sick the patients are, or whether or not they have insurance, or how many patients they see. You don't have to play these games of risk adjustment where you say, oh, well, this is a much sicker population, so they need to get more money or more reimbursement or whatever. These games never benefit people. Ultimately, under Medicare for all, we would move to a global operating budget for hospitals so that we simply pay them to cover the costs of what they spend to care for patients. And in addition, under a system like this, public health authorities could redirect resources quickly and easily to meet local needs. In this COVID pandemic, we have seen healthcare systems on the West Coast sending their ventilators to New York City to help New York City out of the goodness of their hearts, right? This is a crazy way to manage a pandemic. It's absolutely insane to me that we have to depend on the charity of hospitals on the West Coast to say, oh, well, let's be good stewards here and send some ventilators over to the East Coast where they need it. This is nuts, right? In a pandemic, we need our public health authorities to be able to simply say, all right, we're going to move a bunch of ventilators from here to there. This is where they need it. We're going to move PPE, personal protective equipment, from X to Y because this is where it's needed. We could do that so much more easily if we had a single, well-organized Medicare for all type of system. And again, we lack these resources in public health to address emergencies. This has been decades where public health budgets have been either stagnant or actually decreased, and that has completely hamstrung us. It's completely hampered our ability to manage this pandemic. We've seen hospital closures in rural and low-income areas because, of course, they're not profitable because of the number of people that they care for that might be uninsured or how sick people are. And now we don't have enough hospital beds during an emergency. We've seen healthcare workers running out of that personal protective equipment and other supplies, right? Ventilators, masks, the therapies that they need. This puts the healthcare workers at risk. It puts their patients at risk. It puts the entire nation at risk. A Medicare for all system would redirect $600 billion per year of administrative waste to patient care and public health so that we could respond so much better in the setting of this pandemic. If we had stable, predictable funding for hospitals, that means that those hospitals that are in rural or low-income areas will always have the resources that they need to serve their communities during a pandemic, instead of, again, depending on insurance reimbursement, which is clearly not going to work in this context. Another problem that we have in our current American system is that our public health authorities have a difficult time getting accurate data to make decisions on what to do next in this pandemic. Right now, hospitals, healthcare systems across this country use proprietary electronic health record systems. Now, believe it or not, the reason that those electronic health record systems exist isn't to help take care of patients. It's actually to help billing. So all of the electronic medical record systems that are out there are specifically designed to optimize reimbursement for that hospital or doctor. They're actually not designed at all for communicating patient information to a doctor or between two different hospital systems. They are optimized for billing and nothing else. And because of that, they're also not optimized to provide data to public health authorities. And so, the state and local regional health authorities, it's it's difficult to assure that you can collect the data that you need to make decisions about pandemics in this current setting, because every hospital system uses a different proprietary electronic health record that may or may not talk to the health department, or that may or may not talk to other hospitals. And so, authorities must rely on each individual hospital to decide how they're going to report their data, which can potentially delay important policy decisions. One of the things that we see too is that because of this fragmented electronic health record system in this country, if a patient gets seen at hospital A and then needs to go to hospital B doesn't have access to the records from hospital A, and often has to reinvent the wheel for providing care or diagnostic testing for that patient. This just adds further to how expensive and dysfunctional our healthcare system is. So under a Medicare for All system, we could have a unified national electronic record system. And this would mean that if you went to a different doctor, that new doctor would still be able to see everything that that you'd had done previously. But more importantly, we would also be able to communicate that data to our state, local, and regional health departments so that they would be able to monitor, a sudden spike in ill patients in the middle of New York City. This would let them respond in real time to say, wow, last night we saw a bump in patients admitted to the hospital, and that bump seems to be continuing on today. We think there might be a problem. Let's direct some resources. Let's pay a little closer attention to New York City, instead of waiting for those hospitals to actually report, hey, we think we have a problem. We're seeing something going on here. And of course, only a single hospital is only going to know what's going on there. If you actually can monitor regionally, you can say, wow, all of the hospitals in New York City are seeing an increase in people presenting with acute illnesses that look like COVID. Again, maybe we need to be redirecting resources there. And don't forget, we tie health insurance to employment in this country. And just this morning, I heard that 26 million people have lost their jobs. And that means that 26 million people will be losing their health insurance. We've already talked about the fact that if you have no health insurance, you don't seek care. But this is sort of a 1-2 punch, right? Not only do you lose your job, so you lost your income, you lose your health insurance, so you can't pay for it when you get sick. And those 178 million Americans with job-based insurance, they're at great risk during this current pandemic, and we're going to see them get sicker and sicker. And of course, those who do need care, whether it's for COVID-19 or, heaven forbid, you just have a heart attack, right? If you've lost your job and lost your insurance, you're going to face huge medical bills. And that's, of course, going to worsen the effects of this recession. Under Medicare for All, we would create a health insurance system that doesn't connect to your employment. And this would be so liberating for Americans, right? Instead of being stuck with the insurance options that your employer offers, you'd be able to see any doctor that you want under a national health insurance system. Heaven forbid, again, that your doctor is no longer part of the network of insurance plans offered by your employer. Then you can't see that doctor anymore. Or heaven forbid, you have to stay in a job that's not good for you because the insurance is good. Heaven forbid, you're not free to leave to get a new job because you need that insurance, or you develop a pre-existing condition and it's covered at your current job but won't be if you switch jobs and need to get new insurance. And so, Medicare for All system will free Americans to be able to do what's right for them instead of being tied to the narrow networks, the being at the whim of whatever your employer wants to offer for health insurance. And when a pandemic like this strikes, you don't have to worry that you're going to go bankrupt. That you're going to get sick and not be able to pay for your medical care. So we encourage you to take action now. This is the time to educate people, to let people know that the only solution in this public health emergency is an improved single-payer Medicare for all system. Tell Congress, tell the political candidates out there now to support Medicare for all. Write a letter to the editor, write an op-ed, right? Get this published, in your local newspapers or on internet sites to help tell people that this is the solution to our current pandemic. PNHP has a number of different excellent tools to help you get this message out there on social media. You can tell your story, talk about patients that you've known that avoided care, talk about people that you've seen that avoided care and that landed them in the hospital for complications of their illness. Talk about people that you know that lost their job and now can't get the health care or the medications that they need. You can contact your elected officials via social media, and we have tools to help you do that. You can post educational materials and help teach the public about why Medicare for All is the solution in this pandemic. You can engage your family and friends in conversation about it because everybody needs to understand that this is the solution. So my take from this is that, an early lesson from COVID-19 pandemic just reinforces how badly we need single payer Medicare for all. Because of course we all need health care, right? When people don't get treatment for their illness, I mean, that hurts individuals, that hurts communities, and ultimately that's going to hurt our entire nation. We also need our hospitals, but our hospitals are under-resourced. Our hospitals cannot handle the surge in COVID patients that we're seeing right now because our hospitals are built on a fragmented private insurance base that says, oh, you must have insurance to get reimbursed. Oh, you don't have insurance? I guess the hospital is going to have to eat that cost. And so we're watching badly overloaded hospital systems not able to care for patients. They're actually having to make decisions about who lives and who dies. When you don't have enough ventilators, you have to make the horrible decision to say, you will not get a ventilator, therefore you will die. And that is simply a result of inadequate resources because of our fragmented healthcare system. Ultimately, we are all in this together. Nobody is safe from coronavirus. Everybody could get it, and 2% of us will die. But our fragmented healthcare system makes it so difficult to address these healthcare needs during this crisis that we are all facing. So again, I'm a board member for Physicians for a National Health Program. We're a nonprofit, nonpartisan, member-supported 501c3. Anyone can join. Here you have our website, including specific resources towards this COVID-19 pandemic we're facing. You can follow us on Twitter at PNHP or on Facebook. And this webinar was produced as part of our kitchen table campaign. These are topics that we think people should be talking about over the kitchen table, when they're having their breakfast. Let's think about what we can do better. We really want to empower you. We want to empower the public to understand how a single-payer Medicare for all system is really the solution to all of the problems we have in our healthcare system. We focused on several other topics. In January, we focused on surprise billing. We focused on racial health inequities in rural healthcare in February and March. We're now focusing on COVID-19, and we'll tackle high drug prices in the future. I want to take a little bit of time to answer some of the questions that we've gotten around COVID-19. One question is, are there any parts of the healthcare system that are performing well during this pandemic, and what can we learn from them? Well, like I mentioned at the beginning, I think the Medicare system is actually performing well. It quickly responded to say, senior citizens, you're going to be okay. We will make sure that we cover anything related to this pandemic. And that was a model, that was a leader. That meant that private insurance companies followed suit, and that's actually helped the rest of Americans. So that part of this is working well. And honestly, I think our public health systems are doing the absolute best they can. They are working around the clock. They are trying to do contact tracing and contact testing and all of the things that we need them to do. The problem is they have tenfold too few people doing this. We've been starving our public health resources for so long that that they simply don't have the capacity to manage a pandemic on this scale. But I can tell you, they're doing an amazing job with the limited resources that they have. Are there other countries that have handled this crisis particularly well? Some people have asked, and what should we be doing that we've not been doing? What are they doing that we didn't do? People often hold South Korea up as a model for response to this. They've really kept a handle on massive spread of this infection up to this point. And I think that's partly because they had an excellent organized public health effort that included testing people, that included isolating people, that included public health messaging, that included social distancing and the use of masks. They seem to have done a lot of it right, but they could only do that because they were able to direct resources systematically and in an organized fashion into their public health system. And of course, they cover the healthcare costs for people in their country. I think Taiwan is another good example. We mentioned them earlier, that the Taiwanese government stepped up and said, we're going to not just cover your medical costs, we'll cover your food, we'll cover your lodging. This is incredibly brave, but incredibly insightful, right? They know that this is how to protect their community, how to protect their citizens, which is, of course, all we ask of our government in this kind of pandemic. And so I think we look to countries like that, and of course, Taiwan has a single payer system. So that's been a real blessing for them in terms of managing this pandemic and following the epidemiology. Another question: what can we do to save lives today during this pandemic? What do we need to do to prepare for the next public health emergency? So to save lives today, stay home. Keep up the social distancing. Keep up the stay-at-home orders that may be in place in your communities. And I guess you say, why? And how long am I going to have to do that? Well, ultimately, what that does is it buys us time. If we lift those stay-at-home orders, we're going to see a massive spike in the number of people that get coronavirus, and we will rapidly overwhelm the capacity of our hospitals to care for people. We're already seeing this happen in New York City, but imagine this happens across the country. We will see an absolute decimation of our healthcare system. We will see an overwhelming number of patients needing to be seen, and a healthcare system that simply can't deal with it. And of course, our public health systems would never be able to do all of the necessary public health work if everybody is sick, right? And so what you can do today to save lives, the most important thing is to keep up this social distancing. This buys us time. This lets us spread out the number of sick people so that we don't overwhelm the hospital. And hopefully it allows time for vaccines to be developed, for therapies to be developed, for us to build up the infrastructure that we need to handle a public health emergency. And now that we see what sorts of things we need in this country for this pandemic, we can be a little bit smarter in the future. We can develop stockpiles of therapies or ventilators or personal protective equipment and make sure that we are ready to mobilize that when we need it. How would Medicare for All improve health for African Americans or tribal populations or people that experience homelessness? How would Medicare for All help vulnerable populations those communities that are really suffering during this crisis? Well, I think it would help in several ways. First off, we know that these vulnerable populations have more medical problems, right? And so Medicare for All will assure that they can get the care that they need. We also know that they often don't have access to the care that they need. Again, Medicare for All creates the infrastructure to make sure that they can get the care that they need. We also know that there are massive inequities built into our system that, for instance, people, in the inner cities ultimately die on average 16 years earlier than people that live in suburban communities. And so those inequities have to do with healthcare access, they have to do with living conditions, they have to do with untreated illnesses, and so many more social determinants of health. But making sure that everybody gets the health care that they need, the treatments that they need, can get to the hospital when they need to, will go a long way to eliminating those disparities. It won't solve them entirely, but it will make a huge difference. Another question. Single payer advocates want to double public health spending. Well, what would this look like and what would it accomplish? Doubling public health spending will allow our public health departments to develop the infrastructure to handle pandemics like these. If there's anything that this pandemic has revealed, it reveals all the holes, all the flaws, all the inadequacies in our public health systems. It's not that the people that are doing public health don't do a great job, because they do. But, it's hard when you have a small team and a limited infrastructure to be able to handle when thousands and thousands of people suddenly have a terrible disease like this. Many health departments are actually recruiting volunteers, armies of volunteers to help the health department out. And that's great. That's really nice. And I'm glad that people are able to volunteer their time. Of course, many of them, don't have jobs now anyway, so they've got to do something, right? But, the notion that our public health departments are depending on volunteers to do such important work is mind-boggling to me. Absolutely mind-boggling. And so, expanding resources to public health departments means creating the infrastructure to respond to emergencies, shoring up our disease surveillance systems. It means increasing our public education campaigns to help people understand what they need to do to help keep themselves and their loved ones safe in this pandemic. So with that, this will conclude this webinar. I'd like to thank you for your attention. Again, my name is Phil Verhoef. Feel free to reach out to me through PNHP if you have questions, and good luck. Thank you.